Okay, this is Chapter 23, Lecture Video D, and we are going to finish up urine formation by water conservation. Obviously, the kidney eliminates metabolic waste, but it also has to prevent the body from becoming dehydrated. And as kidney returns water to the fluid remaining in the renal tubes is passed as urine, and that does have to become more concentrated. The collecting duct is the part of the kidney, of the nephron, that actually concentrates urine. It begins in the cortex, where it receives the fluid from several nephrons. As the collecting duct passes through the medulla, it reabsorbs water and concentrates the urine. The medullary portion of it is more permeable to water, and as urine passes through that increasing salty medulla, water leaves by osmosis, which allows and helps to really concentrate that urine. The control of water loss, how concentrated the urine is, depends on the body's state of hydration. Obviously, the more you drink, and drinking large volumes is going to produce a large volume of hypotonic urine. So water is going to remain in the urine and you're going to urinate more. This is also called water diuresis. Producing hypertonic urine is when dehydration is in set. This causes you to urinate less, and your urine is a lot more concentrated. More water is reabsorbed by the collecting duct to conserve water because you're not taking in as much. If the blood pressure is low in a dehydrated person, the filtration rate will also be low. That filtrate moves more slowly, which allows for more time for that reabsorption, which again results in less urine produced. Now, we need to talk about the countercurrent multiplier. Now, the ability of the kidney to concentrate urine depends on how salty the medulla is. This is making hypertonic urine. Now, the renal medulla, which again is the inner section, is about 4 times as salty as the cortex. The cortex is the outer part. Now, the nephron loop, which, remember, the segment, the thin, and then the rest of it's the thick segment, acts as what we call a countercurrent multiplier. And what that means is, by multiplier, it means that we are constantly multiplying the salinity in the renal medulla. So it continuously recaptures salt and returns it to the extracellular fluid in the medulla. That multiplies and increases the salinity of the medulla. Countercurrent is because fluid is flowing in opposite directions in adjacent tubes of the loop. So you have the descending limb, fluid flows downward, and then you have the ascending limb, which fluid flows upward. And this is constant, all happening at one time. So this is where it gets the name countercurrent multiplier. The fluid that goes down into the descending limb passes through an environment of increasing osmolarity. Most of the descending limb is very permeable to water, but not to sodium chloride. So water passes from the tube into the ECF, leaving salt behind. And so as the water leaves, that means the fluid inside the tube becomes really, really salty. So when the fluid starts flowing upward into the ascending, water can't leave. So this is when sodium and potassium chlorine are reabsorbed by active transport, and they're returned back into the medulla, which again increases that salinity. It maintains a high osmolarity of the medulla, and the tubular fluid then becomes hypotonic at the top of the loop. The recycling of urea, it occurs at the very end, the lower end of the collecting duct, where it is permeable to urea, and urea contributes to that deep medullary tissue, and it's constantly recycled from the collecting duct to the nephron loop and then back to the collecting duct. So again, very important that you understand this idea that the nephron loop acts as a countercurrent multiplier. And this is where you can see that image. The more salt is continually added by the PCT. So right here in the PCT, you've got salt being added to the extracellular fluid. The higher the osmolarity in the ECF, the more water leaves the descending limb. So you can see the blue arrows in the descending limb, water's coming out into the medulla. The more water that leaves the descending limb, the saltier the fluid is inside the tube. So right here we got really salty fluid in the tube. And then the saltier the fluid in the ascending limb, the more salt that it pumps out into the ECF. So this is where we're going to increase the salt or the salinity in the medulla, as right here in the ascending limb with the red arrows show salts are being pumped out. The more salt that's pumped out of the ascending limb, the saltier the ECF is in the medulla, and then of course more salt is continuously added by the PCT. So that's where you get that whole multiplier effect, because we're constantly putting more salt into the renal medulla. This exchange system, the vasa recta, is a capillary branching off of the efferent arteriole. It provides blood supply to the medulla, but it doesn't remove sodium chloride. This countercurrent system, again, is because blood's flowing in opposite directions in the parallel capillaries. The descending capillaries exchange water for salt. Water fuses out of the capillaries and salt diffuses in. The ascending capillaries exchange salt for water. Water diffuses into and sodium diffuses out of the blood. So they absorb more water on the way out than on the way in, which is carrying away water that's been reabsorbed from the urine. And here's a picture of maintaining the osmolarity inside of the renal medulla. This is getting into the properties of urine. You probably have heard of a urinalysis or had a urinalysis, and this is just the examination of the properties of urine. The appearance, of course, is clear, almost a colorless to deep amber color, and sometimes it's yellow. This depends on your foods, drugs, also diseases can change. Could suggest a urinary tract infection. Pus in the urine is pyuria, which is definitely indicating something's wrong, and hematuria, which is blood in the urine, also indicates there's a problem. The odor, bacteria degrades urea to ammonia, and some foods can impart to aroma. Specific gravity, osmolarity, pH, of course, it's mainly slightly acidic. The chemical composition is mainly water. There's about 5% of solutes. This is a great list of things that are normal to find in urine: urea, sodium chloride, potassium chloride, creatinine, uric acid, phosphates, sulfates, traces, and some other elements. And then it gives you a list of things that are abnormal to find: glucose, hemoglobin, which is protein, albumin, which is protein, ketone, bile pigments. These are things that are supposed to be reabsorbed by the kidney, and if they're in the urine, it does indicate there's some problem, either trauma or infection in the kidney. Urine volume, the average is 1 to 2 liters per day. Anything in excess of that is polyuria. Oliguria is less than that, and anuria is extremely low urine output. Diabetes is a metabolic disorder that results in chronic polyuria. There are 4 types of diabetes. All of them result in a very, very increased urine output. And you can also find glucose in the urine as well. Diuretics, this is any chemical that increases urine volume to lower blood pressure. This is treated. Caffeine actually helps dilate the afferent arteriole. Alcohol inhibits ADH secretion. This is commonly used, diuretics are used to treat hypertension and congestive heart failure patients because it's used to treat an increased blood pressure. It reduces the blood volume, reduces blood pressure by increasing the amount of urine output. These are just some renal function tests. What they do, of course, they diagnose kidney diseases, evaluate how severe it is, monitor the progress, determine renal clearance, and the filtration rate. Renal clearance is just what you think it would be. It's the volume of blood pressure from which a particular waste is completely removed in 1 minute. And it's basically a net effect of 3 processes: glomerular filtration, tubular secretion, and tubular reabsorption. All of that determines renal clearance. You can collect blood and urine samples to determine renal clearance, and this is, again, something that they do in conjunction with a urinalysis. The filtration rate, kidney disease often results in a low filtration rate, so if a patient is suspected to have kidney disease, they will need to measure the GFR. They can't use the clearance rate of urea because it's reabsorbed in the tube and some is secreted in the tube. So they use a substance that is not secreted or reabsorbed at all, so that all of it gets in the urine by glomerular filtration. So they use a plant polysaccharide called inulin, and this again is neither absorbed absorbed nor secreted by the tube, and it can definitely give you a true indication of renal clearance. And it's estimated clinically by creatinine excretion. Storage and elimination. Obviously, urine's produced continually. It doesn't drain continually from the body. Urination is made possible when we allow it, and there are some neural controls. The ureters are the tubes that connect the kidney to the bladder. They have three layers: the adventitia, the muscularis, and the mucosa. And so anyway, everybody has seen, we've talked about the ureters. The bladder is a muscular sac that constantly is expanded and constricted. It also has three layers, and it gives you those parietal peritoneum, muscularis, and mucosa. It also has the trigone, which is a smooth surface triangular area that marks the opening of the ureter and the urethra. This gives you the capacity of the bladder. Moderate capacity is about 500 milliliters. Maximum is about 700 to 800. As it fills, it expands superiorly. And of course, this is something that everybody has experienced. You do get to a point where you must empty the bladder. And of course, there's a good an anatomical image of the bladder. The female urethra is bound to the vaginal wall. This is where urine actually excretes from the body. There's an internal urethral sphincter, which is, again, a round muscle, a round-shaped muscle. It is smooth muscle, so it's an involuntary control, and this is what allows the urethra to open to allow urination to come out. And it's on the bladder end of the urethra. And then the external urethral sphincter is on the external surface of, it faces the external region where urine leaves the body. And it's where the urethra basically passes through the floor, and it is skeletal muscle, which is under voluntary control. So that's interesting. Once that urine gets into the urethra, this is when you have that urge to go very bad, and if you don't go, then of course it becomes very painful. The male urethra also has an internal and an external urethral sphincter. It also has three regions. It shows you the prostatic, the membranous, and the spongy urethra. Voiding urine, between acts of urination, the bladder fills. Micturition is the act of urinating, and there is a reflex that partly controls that. Involuntary control is when the bladder fills to about 200 milliliters, and you're going to see it starts exciting the stretch receptors. Motor signals travel from the pelvic nerve to the spinal cord to that then to the motor nerves by parasympathetic ganglion. This excites the detrusor muscle and relaxes that internal urethral sphincter, and this results in emptying the bladder. If there was no voluntary control over urination, then reflex would be the only means of control, which is predominant in infants, which is why babies can't control when they urinate. And then the voluntary control, and this is the micturition center, which is located in the pons. There's actually a urinating center in the brain that receives input from the bladder stretch receptors. When they start firing, that's when you get the urge to go. Sometimes it can be prompted by fear or anxiety. If you ignore it, eventually those neurons get tired, so they're going to stop firing. But once the volume of the bladder continues to increase, reaching capacity, those neurons will come back with a vengeance, and you will have to go. And again, most of you have probably experienced this before. And this is when that urge comes. There are some times when, again, when that bladder tension increases, the signals return with not only with persistence, but also with increasing frequency. Sometimes you don't have to, you feel like you have to go, but your bladder's not full, but you want to go anyway. Like if you're getting in a car or going to be a point in time where you can't go to the bathroom for a long period of time, you want to go ahead and empty the bladder. You can use the Valsalva maneuver to compress the bladder, and that will, of course, allow urine to come out as well. And we talked about the Valsalva maneuvers when you really complex and contract that abdominal cavity. This is just showing that neural control of micturition. This shows you the involuntary reflex and, of course, the voluntary control. So really interesting how urinating is actually can kind of undergo two different controls, the involuntary and the voluntary. And that concludes chapter 23.